Hi, this is Dr. Bernhard with IR Centers at Urology Associates here in Nashville, Tennessee. We're here for a webinar tonight to discuss understanding prostate artery embolization, uh, or PAE, which is a minimally invasive treatment, surgical treatment for enlarged prostates. If you're somebody that frequently goes to the bathroom during the day or even the night, has difficulty with your urinary stream, have been told that your prostate is enlarged, this may be of interest to you. You're definitely not alone. A lot of people think they're the only person dealing with this issue, but you don't need to deal with it. You can actually get on with controlling your life and living a full life again. So with that, we're going to get into the talk. So a lot of you are already patients at Urology Associates, but they are the largest practice in Middle Tennessee and Southern Kentucky, offering the full spectrum of urologic services. And IR Centers is the newest wing of Urology Associates, offering minimally invasive therapeutics that can benefit all patients. A little about me. Um, I'm a board certified vascular and interventional radiologist with 12 years of post-training experience. And for those of you who don't know what interventional radiologists are, we'll discuss that in just a moment. Um, while IR Centers at Urology Associates is a relatively new arm, I've been practicing interventional radiology in Nashville for 11 years, previously as the chief of interventional radiology at St. Thomas Midtown. I did my medical school at the University of Arizona and all of my radiology training at the University of Virginia in Charlottesville, Virginia, prior to coming to Nashville. I have particular interest in our topic for today, prostate artery embolization, as well as the treatment of painful varices in the pelvis for both men and women, known as varicoceles in men and known as pelvic congestion syndrome in women. I also have a special interest in uterine fibroid embolization treatment for women, as well as hemorrhoid artery embolization for internal hemorrhoids. Topics for a future date. So tonight's discussion is overall outline is broken down into what is benign prostatic hyperplasia or BPH, what is prostate artery embolization, and how does that relate to BPH, and then sort of the process of the procedure and the expectations and common questions before we get into the question analysis. So first of all, what is BPH and what happens with BPH? So you see this slide, the graphic on the left side shows a normal prostate and bladder, and the prostate is the walnut-sized structure that sits below the bladder and has a number of functions of interest to us, is regulating the flow of urine through the urethra and out the penis. Now, when you're a nice, healthy 25-year-old, your prostate might look like the one on the left, where it's small and you have a nice open urethra. And as people age and a variety of other medical factors, patients' prostates tend to grow. Men's prostates grow. And as they grow, they tend to impinge upon both the bladder, as you can see it pushing up on the bladder, as well as narrowing the urethra. I always tell patients, think of your urethra like a garden hose and think of the enlarged prostate like a foot stepping on the garden hose. Well, water's not going to come out of the hose very well until you relieve the pressure on the hose. And that's essentially what we're doing. For those of you who are scientifically minded, you can see that equation in the bottom left-hand corner. And basically the takeaway is that the radius of your urethra to the fourth power is the dominant factor in your flow. So you imagine if you reduce your urethra diameter or radius by a small amount, it has a massive impact on your flow. So why is this important? Why do we care about this walnut-sized structure? Well, it's as people age, it becomes increasingly a dominating force in their life. As many people on this webinar can attest to, you know, you are constantly wondering where the next bathroom is and how long it will take you to get there as you get older. And so this affects 90% of men at over the age of 85 and 75% at 70, and I believe 80% by the time you hit 80. So this affects 15 million men in the United States, over 50% of men over 50 and 80% over 80. And about half of patients avoid treatment because of fear of side effects. And avoiding treatment not only has an impact on your urinary flow, it also can impact your sleep, which impacts your cognitive function, overall well-being, and longevity, as well as, in fact, impacting a number of other factors, erectile function, uh, to name one more. Um, so you may have been told that your prostate is large. I see patients that come in and say, I was told my prostate is big or huge or massive or ginormous even. So what does that mean? So here's a helpful comparison. Like I said, a normal prostate is about 20 cc's in volume, size of a walnut. And as it grows, once we get into ping pong ball size, we're starting to consider it to be enlarged. And then we move on from golf ball to clementine to tennis ball. And for all the pickleball fans out there, a pickleball is 200 cc's. So we do see patients with pickleball-sized prostates that have pretty significant symptoms that are limiting their pickleball game. So how do we assess your symptoms? We know you've got an enlarged prostate. Just because it's the size of a tennis ball or a clementine doesn't mean it has worse or better symptoms. And we break it down into what are called irritative and obstructive symptoms. Those symptoms of the irritative side are going more often. When you got to go right away. Getting up in the middle of the night, 3, 4, 5 times, and going when you don't want to go because you just got to go right then and you can't get to the bathroom. On the other side, there are the obstructive symptoms, and those are related to your body not able to pass your urine through your urethra due to that foot stepping on the garden hose, as is your urethra. You know, you have a weak urinary stream, or you stop and start. You strain to go to the bathroom. You dribble. You walk away thinking you're done, and then more urine comes out. Or you're just not able to empty your bladder completely, and you walk around with a half full bladder despite having just gone to the bathroom. So there's a standardized form that we use to assess all these features, and the writing's a little small here on the right, but it's the IPSS score, which basically gauges you on 7 different factors and creates a score as well as a quality of life score. And you can use that to assess where you are in the symptom severity. Anecdotally, I was at home talking to my dad, and I was telling him that this was a good procedure if he had issues. And he said, "Oh, my issues aren't that severe, so probably not for me." I had him take this score, this questionnaire, and he came back with a severe quality of life score, or sorry, severe symptom score and quality of life score. He's since had the procedure and says that he pees like a 25-year-old. So you've got an enlarged prostate, you've got some symptoms, you've been to the urologist, you've been started on various medications, which either work great for you, but you can't tolerate the side effects, or just don't really do anything for you. So that's when you start thinking about other approaches that are beyond medication, when medications don't solve your issues. So there are several treatments. the first and third and fourth columns are transurethral treatments, meaning we go through the penis and the urethra. Your urologist for the Urolift, the Rezūm, and the aquablation would go through the penis and the urethra to do the treatment on the prostate itself. The second column is prostate artery embolization, which doesn't go through the penis and the urethra to do the treatment. It goes through the arteries. And that is done by us, the interventional radiologists, versus the other treatments, which are done by your urologist. So just a brief aside, I'm an interventional radiologist. We work very closely with Urology Associates, with all of the urologists to provide an additional arm of care for patients at Urology Associates. Interventional radiologists are radiologists by training that have special surgical skills using image guidance to, in this case, guide catheters and wires using X-ray through blood vessels to deliver novel therapies throughout the body. We work in all areas of the body, not just in the areas of the prostate. These procedures are extremely minimally invasive, often done through a needle puncture with no need for closure of incision with sutures or other more invasive techniques. Typically, these are outpatient procedures where you go home the same day. So they're done with sedation, not usually a general anesthetic, often moderate sedation, and even just a local anesthetic for those that can't tolerate sedation. The recovery is much, much faster, and we're allowed to tailor the treatment to each patient and in real time during the procedure. So I mentioned prostate artery embolization, but just to back up, we in our field use the word embolization. We throw it around every day, but most people aren't familiar with that term. And really what it is just a minimally invasive technique to block or close off blood vessels to treat a variety of conditions, from benign tissue growth in the case of the prostate, cancers in the case of the liver and other organs, to reduce inflammation in joints and other areas, to stop bleeding in the setting of emergency trauma or gastrointestinal hemorrhage, and a number of other different applications. So as we've touched on, prostate artery embolization is a technique where we go through the blood vessels to reduce the blood flow to the target. In this case, the target is the prostate, with the goal of shrinking down the prostate and relieving the pressure on the urethra, taking the foot off the garden hose, so to speak. And this procedure, like I said, is minimally invasive. It's an outpatient procedure. It's office-based. It uses moderate sedation, doesn't require moderate sedation. We go through the artery, you go home the same day, and a relatively short recovery time. Here's a 3D rendering of what we're doing. You'll see a catheter navigating through the arteries, past the artery to the bladder, to find the artery to the prostate, and deliver small beads, usually on the order of 200 microns, medical grade plastic, to decrease the blood flow and shrink down the prostate gland. And what you can see on the right is a small picture of a prostate before embolization on the left and after embolization on the right. So it's significantly reduced in size, and that reduces the mechanical effect on your urethra. Here is a live procedure sped up rapidly. This procedure doesn't happen quite this fast, though some people are just about this fast. And what you see in the upper left is the operator doing what he does to guide the wire and catheter that you see on the right screen through the blood vessels, which are outlined in white. And then he delivers, once he's defined the prostate, he delivers And it's embolic treatment, which you can see there, staining or lodging in the prostate gland, which will then result in decreased blood flow and shrinkage of the prostate. This is live fluoroscopy. This is what's used during the procedure. So what happens after you have this procedure? The procedure typically takes on average 60 minutes, dependent on patient's anatomy and other technical factors. It can be as quick as 30 minutes or as long as 90 minutes, but on average 60 minutes. After that 60-minute procedure, you recover for anywhere from 60 to 120 minutes, 1 to 2 hours with your leg flat to minimize the risk of any bleeding. Excuse me. You may have some soreness at the site for about 48 to 72 hours, and you won't be able to drive after the procedure for 24 hours or lift anything heavy for 7 days. If you want to get up and go for a walk the next day and you can tolerate it, you can do that, but no heavy lifting. So all procedures have risks, and what are some of the expectations after the procedure? So first, the expectations, it's not uncommon or it is expected for you to have burning and frequency of urination, typically for around 1 week, sometimes up to 2 weeks after the procedure. You'll get a number of medications that you'll take during the first week that will help to minimize those symptoms and get you through that postoperative period without too much discomfort. Once you've gotten through that period, you should start to see improvement, sometimes as early as 2 weeks, but often into the 3 and 4 week margin, you'll start to see improvement in your urinary symptoms, maybe going to the bathroom less frequently, being able to empty your bladder more each time you go, not getting up as much at night. All of these are improvements that we look for. And we use that IPSS symptom score to assess this. At 2 to 3 months, you start to see more improvement. Usually by about 3 months is where we expect people to land at their new baseline improvement. But some people get there much sooner. And this procedure typically has a durability of about 5 to 10 years of symptom improvement, with the median being 7 years. All treatments for the prostate, whether they be prostate artery embolization or treatments such as Urolift or aquablation, do have a certain durability or half-life. And this is in keeping with those. If your symptoms come back after that period of time, it is repeatable if you wish to have it repeated. Some people never need it, and some people do. Once again, to quote my dad, who said, "If I have to have this done again in 7 years, who cares, because it was such an easy process in the first place for the amount of relief I got." So just something to consider. All procedures do have risks, though this has probably the lowest risk profile of all prostate procedures. The most common thing we see is a bruise, or what's called a hematoma under the skin at the site in the artery where we access the blood vessel, on the order of 1%. Generally, when we use a small closure device, that risk is further minimized, but we do see it about 1 out of every 100 patients. As we move into the risks that are below 0.5%, we start to see patients that go into what's called acute urinary retention, where after the procedure, they just aren't able to pee due to the inflammation of the prostate expected after the procedure. Usually, medical management can get them through this process, but about 1 in 500 people needs to have a catheter put into their bladder for about 5 to 7 days. And then it can be removed and typically does not need to be replaced. That's the only situation in which we require a catheter, would require a catheter in the process of this procedure. Now, non-target embolization occurs in roughly 1 in 1,000 patients. And what that means is embolization is the depositing of particles into the target, in this case, the prostate. So non-target means the particles, through various ways, are getting to places other than the target. through small communications. This is avoided in expert hands by knowing what to look for and how to deliver the treatment so as to minimize the potential risk while delivering the most maximal treatment for the patient. So when am I going to see symptom improvement, or when do I get to pee normally again? Like we said, this is just a graphical representation of sort of what we already talked about, with the symptom improvement progressing over a month. And you can see we're referencing that IPSS score again. And it trails off with 3 months is where it sort of levels out up to that 5 to 10-year durability. Now, there are some special considerations that we think about with this procedure. So a lot of patients who are on blood thinners have to come off them for prostate procedures. We typically like to hold anticoagulants for 2 days prior to the procedure, unless you strictly cannot come off them. And then it is doable. There's just a slightly elevated risk of bleeding. And what are anticoagulants? If you take Eliquis, if you take Xarelto, if you take Coumadin, those are the 3 most common anticoagulants. Those are different from antiplatelet medications, which we do not require that you hold. So if you take Plavix, Brilinta, Effient, those are medications you do not need to hold for this procedure. An additional consideration, we already touched on this a little bit. What about the bladder? Well, if you are coming in because you have a catheter in your bladder because you are unable to urinate on your own, then we do not take that catheter out for the procedure. We do not do anything with that catheter. And we do not place a catheter for those that don't already have one for the procedure, which is something that's different from most of the procedures that go through the urethra, where patients typically have a catheter for a period of time afterwards. If you are one of those people that has a catheter coming in, we like to try and get the catheter out in 2 to 4 weeks, dependent on how long it's been in and what your symptoms are. And that typically involves what's called a voiding trial, where you go into the office, catheter is removed, drink a lot of fluids, and then you sit around until you feel like you can pee. And if the catheter comes out, then it stays out. Now, some patients come in and they have what's called bladder dysfunction, or maybe their bladder isn't squeezing as well. The bladder is a muscle. And those patients can still benefit from this procedure, but assessing the degree of bladder dysfunction is an important conversation to have in order to understand what the potential benefits of this procedure would be for them. And that's a discussion that you could have at the time of your consultation. So who's a candidate? Well, we've touched on quite a bit of this, but just to reiterate it, typically candidates are people that have an enlarged prostate and they have symptoms related to it. Most patients are on medication, and either they're not getting the relief they want, they don't like taking medication, or they can't take the medication due to a number of reasons, most commonly side effects. Patients that have bleeding from their prostate are an excellent candidate for this procedure because we are significantly reducing the blood flow to the prostate, which drastically reduces the likelihood that the prostate would bleed. Now, in addition, this procedure can be used for patients with prostate cancer. The evidence we have suggests that it does not affect the prostate cancer in terms of it will not make it spread. We can't say it'll make it go away, but we can do this treatment for patients that have enlarged prostates in the setting of prostate cancer. For patients that maybe if their prostate were smaller, their radiation treatment with their radiation oncologist would be safer and more effective with fewer side effects. It's an ideal treatment for that. We don't treat patients that have active infections because there is a risk of transmitting that infection to the bloodstream and causing a life-threatening bloodstream infection. Aside from those features, you need to be somebody who can lie flat on a table for an hour. If you know yourself and your back is twisted in knots, or you can't lay your leg flat, then you might not be able to tolerate the procedure. You'll have to lie flat for the recovery as well. And I know this was a question I got previously, but I'll just touch on it here. If you're taking prostate medications, it is not a contraindication or a reason that you cannot undergo this procedure. The majority of the patients we see are taking prostate medications. Is it our goal to get you off those medications? Ultimately, yes. We don't take you off of them right after the procedure. We typically wait several months to see the effects of the procedure so that we know what benefit you've gotten rather than changing too many variables at once. So you're a candidate for the procedure. You have an enlarged prostate. You want to have this done. What does that process look like? Well, typically there's a 15 to 20 minute audio visual telehealth consultation with myself or one of my colleagues. And for those that, for various reasons, want to do an in-person consult, we do offer a few appointments for that. Sometimes it's a language barrier, or people don't like using the phone, or don't know how to use video on their phone. Those are all reasons. So once we've done the consultation, then we schedule the procedure. Now, how long is that going to take to get you scheduled? It's highly variable on the schedule. Right now is at the time of the year where everyone's trying to get in under their deductibles. It may be a little bit of a longer wait, but other times of the year, it may be a little shorter. Sometimes we have cancellations and people can pop into an open spot in a week's time. Is this covered by insurance, or what's the insurance authorization process? We have a whole team at IR centers that deals with this and is very facile with all the different insurance companies and knowing who needs what and how quickly they need it in order for it to be approved. Now, this is covered by Medicare, which wasn't the case about 5 or 6 years ago. And that, since it's been covered by Medicare, has led to a significant increase in interest and demand for this procedure because patients now don't have to pay out of pocket, which is obviously prohibitive for most people. So after you've scheduled the consult and you've gotten approved by insurance, you're going to get a call a week before the procedure. The nurse is going to tell you all the things you need to do. Nothing to eat or drink before midnight, what to expect, a little bit of the same things we've talked about today and you talk about in the consultation. Then you come for your procedure. Typically, you're in our office 3 to 4 hours, an hour before, an hour for the procedure, and an hour after before you go home. You'll get a call the next day from our nursing staff, just following up, making sure that you're doing okay. The medications, you're taking the medications and you're tolerating the symptoms. You're not having issues such as bleeding or fevers, things like that. You'll get another call, a phone follow-up call in 4 weeks to see how your symptoms are going. So that's generally the process surrounding the prostate artery embolization. So in summary, before we get to the QA and answer any questions people have, just in summary, this is a PAE, or prostate artery embolization, is a minimally invasive outpatient office-based procedure where you go home the same day to treat the enlarged prostate by restricting the blood flow, causing it to shrink down. It's a great treatment option for many patients because it doesn't require going to the hospital or general anesthesia or a lot of other factors that some patients just can't tolerate due to various other health concerns or healthcare goals. It's something you can speak with your urologist about and see if it's an option for you. You can speak with our office and see if it's an option for you there as well. You can make an appointment with me for a consultation to decide if it's something you want to do. If you decide, nah, it's not for me, then that's fine. But at least we've had the conversation and you know what you're getting into. And this is our number. I'll show you again later. So we're going to open it up to questions. Any questions for people? I'm going to try and figure out where I can see these questions.
So hello everyone. My name is Dr. Alex Puigba. I'm Dr. Bernhard's partner working in Virginia with IR centers or prostate centers. I've been answering some of the questions through the chat in the Q&A section. There's probably two more that I haven't gotten to yet. So we can
Oh,
talk
thanks,
about
Alex.
those. Yeah. Um, some of them are more individually framed. Um, So this patient asked, anonymous attendee, I have extremely large prostate, 250 cc's. I'm 69, however, few symptoms at this time. Would like to stay ahead of the game as my prostate will grow. I'm also taking alphazocin and would like to get off of it. Am I a candidate despite severe symptoms? I think they meant to say despite not having severe symptoms at this time.
Well, a question would be do you have severe symptoms when you stop your medication or before your medications were your symptoms severe? Because one thing we have to keep in mind, so to answer your question, the short answer is yes, I would say that you are a candidate for that reason to stay ahead of the game and to protect not only your prostate, but also your bladder and your kidneys. Because one thing that we have to keep in mind is the medical treatments such as alfusen, they're very good medications for those that can tolerate them. They're very good at improving your symptoms. They're also very good at masking the effort that your bladder is putting forward in the background. You know, your bladder is a muscle, and if it's trying to squeeze a certain volume of fluid through a tiny hole, it's going to have to exert more force to overcome that narrowing. And so over time, what we see in a lot of patients is they go to get an MRI for their prostate to look at the size, and they say, your prostate's 150 cc's or 250 cc's. Oh, and by the way, your bladder is kind of thick, which means you're overworking your bladder muscle. And over time, your bladder can fatigue. And you don't want to get into a situation where your bladder doesn't work as well, because then any treatment, whether it's TURP or aquablation or PAE, is going to not give you as durable or as effective a result as you might otherwise get if you had intact bladder function. I hope that answered that.
I think that, yeah, and I totally agree. Um, some of these people are asking for other docs in different areas of the country. We kind of answered this, the risk of prostate necrosis and causing sepsis. Um, Not really necrosis. You can have some tissue sloughing or a small amount of tissue of the prostate gland go into the urethra and you have to urinate it out, but that's very rare. It's on the order of, I'd put it in that less than 1% category. And sepsis related to the a PAE itself is very rare. I've actually never seen that. Um, how would HOLEP potentially have the side effect of erectile issues? So they're asking a question about HOLEP, which it's a different procedure than what Dr. Bernhard was talking about today, but it's a resective procedure where they basically use a laser to carve out prostate tissue, which it does carry risks for erectile dysfunction. But just to reiterate what Dr. Bernhard said, there's no risk for erectile dysfunction, no significant ejaculatory issues. Um, I also my prostate is 90. Um, Sorry, a bunch of questions are flying in. My
Yeah,
prostate is
I
90
can I
cc.
can see them now.
Oh, you can
So
see it. Okay, great.
um, Yeah, so prostate is 90 cc's. Would you be a candidate? No medications and mild symptoms. Uh, yes, you would be a candidate. It's just a question of having the discussion, is it something, are you someone that would tolerate medications and would those get rid of your mild symptoms and maybe buy you some more time? Or are you somebody who doesn't like taking medications and would prefer to just deal with the prostate and move on. So it's you would be a candidate, but it would have to be a discussion on what your expectations are, what your preferences are in terms of taking medications versus undergoing procedures, which do carry small risks. Um, Prostate causing blockage to a spasming bladder. The prostate is 35 cc, and I was told it's of a smaller size. Urolift might be best. Could this be a better alternative? Do I need to have a larger prostate for this? Um, well, what we see is that we do see this subset of patients where they tend to have a smaller prostate, but they have pretty significant symptoms, and they're more on the irritative side of symptoms. So they're going frequently, getting up in the middle of the night a lot. So these patients do equally well with prostate artery embolization. It is a more technically challenging procedure, but it is an option for patients such as yourself. Um, is Urolift best? I won't speak for the urologists on that aspect, but Urolift is certainly an option for somebody with a prostate less than 80 grams. We have seen some patients who have gotten Urolift and their prostate continues to grow, and over time it sort of overwhelms the Urolift because the Urolift is only sort of validated up to about an 80-gram prostate, 80 cc's, and the prostate, when they got the treatment, was below 80 cc's, and now a few years later is gotten much larger. For recovery by lying flat, do you mean with no pillows or inclination of the body, or would it be okay to have a pillow under the head or knees? So good question. We typically elevate the bed. We like to have people's the blood vessel that we access, typically the right side. We like that leg to be straight for the full hour of the procedure. We don't typically have people's knees bent very much. A small pillow we can place under the knees for the procedure and under the head as well. But we can't have very much flexion at the hip joint. Do we have an office in Brentwood? There's only one office in Nashville. It is in Nashville proper on 21st Ave, exit 3 off the 440. You basically exit north off the 440 and it's about 1 block. So it's probably about a 10-minute drive from Brentwood, but we do not have any other offices in Nashville. There's a lot of discussions about microplastics and their long-term health effects. Do the materials used in PAE carry any risk of breaking down into microplastics inside the body? That's a good question. I don't honestly know the answer to that question. The volume of plastic, however, that we are injecting into the blood vessels that's lodging in the prostate and not circulating throughout the body, the volume of that plastic is extremely small. These are 200 micron particles, and the volume that we are injecting is, on the order of 1 to 2 milliliters in a larger prostate. So in comparison to the amount of plastics you acquire in your body throughout your life, it's probably inconsequential, but I don't have any data specific to that. I don't know, Alex, if you have any thoughts on that.
Yeah, I mean, there's no long-term data over what happens with these particles. We do know that they kind of get eaten away by macrophages, which are cells in the body that basically help clean up any foreign debris. But these materials that we use for these procedures have been used for decades in the body, without any long-term consequences. Honestly, if you're wearing polyester or using all these other things in your body, drinking from plastic water bottles, you're gonna have more exposure to plastic doing that than you are with this procedure.
Do you want to answer that next one by, it looks like you're typing an answer to the painful urination question, but
So yeah, so what causes painful urination after PAE? What is the source of painful urination if you don't go through the penis? What is the nature of the pain? So after you embolize the prostate, you're basically depriving the prostate of what it needs. The oxygen needs to grow, the oxygen and nutrients that comes from the arterial blood supply. Now when you do that, there's actually an acute phase or period of inflammation. That inflammation will can cause burning when the urine passes through the urethra where the prostate lives around. So that in itself can cause burning on urination. That inflammation is also why there can be frequency, or you pee more frequently immediately after the procedure. We have a medication regimen that can help with that burning on urination, and that frequency may not take it away, but it usually makes it um, comfortable so patients can tolerate just for those couple days.
another question is, I'm not sure what the size of my prostate is. Do you need to know the prostate size beforehand? Would you, would the interventional radiologist or the urologist suggest the needed tests such as MRI and be the physician who would order this to gather this information? Most commonly, patients come to the interventional radiology center via their urologist. And most commonly, patients have had some degree of workup beforehand. So whether that involves an MRI, which we commonly see because a lot of patients with enlarged prostates have elevated PSA levels. And so would like to exclude cancer. Or patients have had a scope of their bladder and their prostate for either symptoms or issues with bleeding. So generally some degree of workup with the urologist is done before they're referred to us. Okay. Does this procedure help ED? So it is not a treatment for erectile dysfunction. The caveat that we see is that we do see patients that have improvement in their erectile function following PAE. I don't know of any data that explains this, and Alex, you can chime in if you do, but in my mind, I think of two factors. One, you're not in a process of chronic inflammation in your bladder and your urethra related to your prostate obstructing your urine flow. And also, you are not getting up 6, 7 times a night, which impacts your quality of sleep and your libido. And so those two factors to me are probably why we do see patients have an improvement in erectile function, but this is not considered a treatment for it.
Yeah, the other impact that people can have when it comes to sexual dysfunction is they may be on medications that can impair their sexual function, whether it's finasteride or tamsulosin. And vast majority of men, after they have a PAE, will be able to come off those medications. So even though PAE directly does not improve erectile function, indirectly it can, because some of those things that Dr. Bernhard alluded to, and then also being able to come off those medications can potentially help.
Yeah, good point.
I think this is great.
How does PAE affect your PSA level in enlarged prostate? That's a great question. And an important one to touch on because it will in time lower your PSA level as your prostate shrinks down, but there will be a period after the PAE where your PSA level goes up substantially. And so it's important. What do you say? 3 months or 6 months, Alex?
I'd say 3 months.
Yeah,
So it goes hand in hand with getting the maximal shrinkage of your prostate, which usually occurs around um 12 weeks or around 3 months. Um, like Dr. Bernhard said, in that phase of inflammation, you actually have a spike or peak in your PSA because your prostate's going to leak PSA. It doesn't mean you have cancer, but it's actually when the prostate gets embolized, there's that inflammation causes a leak of PSA. Just like if you were to have prostatitis or an infection of your prostate, PSA will go up. Doesn't mean that you have prostate cancer. But then you reach this new steady state or this new level once the prostate shrinks, which is usually a fraction of what the initial PSA was. So patients who have low grade prostate cancer, or they use like a Gleason score, so like a Gleason score of 6, who are on like active surveillance, meaning they're not planned for surgery or any type of radiation or anything like that, but rather just watching them. Sometimes those patients don't need as many biopsies because their PSA just is at a lower level, so they don't need biopsies sometimes. But this procedure does not treat prostate cancer. Your PSA should continue to be monitored by your urologist.
correct. Please cover again how long I can't drive. Typically, we say no driving for 24 hours. And in part, that's because you've gotten sedation. The large part is because you've gotten sedation and you shouldn't be driving for 24 hours or operating heavy machinery. And also, we don't want to get in a situation where you're exerting a lot of force on the site in the artery where we were operated so that you increase the risk of bleeding. So those are the two primary reasons. Another question, this procedure you say will block the artery around the prostate. Are these arteries not needed for the prostate? Excellent question. So typically, the prostate receives some blood flow from a number of different arteries in the pelvis. There is a rich network of blood vessels that cross fill, but the artery that we are occluding is the main artery to the central aspect of the prostate, which is the aspect of the prostate that gives you the most symptoms. So we are dramatically restricting the blood flow of the prostate, which is restricting the prostate's ability to receive the nutrients it needs in order to maintain its abnormally large size. And as a result, it will shrink down. The normal size prostate is not a very vascular organ that does not require a large blood supply. So we are attempting to return it to that natural state. Will post-procedure inflammation result in lower urine flow while it is inflamed? Certainly that is a possibility, and that speaks to what we talked about with urinary retention after the procedure. In patients that tend to retain urine, they may be at higher risk of going into acute urinary retention, which would require having a catheter placed in, because that degree of inflammation, they've been squeaking by for so long, and that degree of inflammation just slams the door shut. Will the procedure leave a scar or mark on the body or belly? Typically no. The nick we're making in the skin is just big enough to get basically a catheter the size of a spaghetti noodle into the skin. When patients go home and they go to shower, we tell them to take the bandage off and just put a regular Band-Aid over their incision, and it should heal up within 3 to 5 days. So typically there's not a significant scarring event or mark unless somebody is prone to scars such as forming keloids or something like that. Does PAE target the zones of the prostate that are adjacent to the urethra or the entire prostate? We sort of touched on that with the other question. It targets the entire prostate, but the zone adjacent to the urethra is the one that causes the most symptoms, and so that's where we're trying to get the densest delivery of our particles to get the maximal shrinkage and improvement in symptoms. How long has PAE been practiced, and over what time span do the existing longitudinal studies extend? Good question. So PAE has been in the United States for probably 14, 15 years, and has become more available, like I said, due to changes in Medicare funding. Prior to that, it's been practiced probably for 25 years, I would say, roughly. A lot of the original longitudinal studies were done in Portugal and Brazil, and then has come over to the US, some in Japan, but has come over to the US, and a large body of evidence has been generated by our practice as well as other institutions in places like Miami, and North Carolina. So we have on our website, ircenters.com, we have a page that has links to a number of different publications where you can go and review data. There's meta-analyses, which compare a number of different types of studies on prostate embolization, studies that look at different sizes. All sorts of different publications are available on that website for review. When can I resume flying after the procedure? Well, probably as soon as you can resume driving, but keep in mind that during the recovery period, you will be having to urinate frequently. So if you carry a bathroom with you, then you could probably go flying a day or so later. But
maybe get an aisle seat.
yeah. Or yeah, if you're in your own plane, you have something that you can urinate into. If you're flying on an airplane, yeah, aisle seat, or I would wait a few days. We do encourage people to not travel for a week after the procedure, just so you don't get into a situation where you're somewhere where you can't reach out to us for help if you're having any issues related to the procedure, or you need to come into the office to be evaluated. Let's see.
Oh, we got a patient in here.
All right. Hey, Mr. Osborne. Yeah, well, there we go. We have a patient from today. He had his PAE today, and he said, easy, no pain process, looking forward to results. That's right. He was thinking this webinar was going to be last night so he could be ready for it, but not the case. Let's see. So one person asked to contrast with TURP, which reduces size of the prostate the most. Well, TURP reduces the size of the prostate by essentially carving out tissue around the urethra. So it doesn't address the overall size of the prostate. It more addresses sort of boring a channel through which you can urinate. So we get like a global reduction in the size of the prostate, as well as shrinking that area around the urethra, which opens it up. So they're kind of mechanically different processes. TURP does tend to carry a few more side effects. There's concerns about incontinence and retrograde ejaculation that do turn some people off or have them, consider PAE over TURP. But again, that's a discussion with your urologist in terms of what your prostate looks like, what your overall goals are in terms of how quickly you're looking for results, and what you're willing to undergo and what you medically are able to tolerate. Let's see. How long have the two of you been performing PAE? Roughly how many procedures have you performed? I've been performing it for about 7 years. This center opened up about that I work at opened up about 2 weeks ago. Sorry, 2 months ago. But prior to that, I was performing it at St. Thomas Midtown. Um, and Dr. Puitapa is gonna put me to shame with his numbers.
Yeah, no, I mean, so I would say as a whole, our practice, we have about 40 docs. We account for probably more than with 40 docs, you probably account for more than half of the PAEs that are performed in the United States. So to put that in perspective, all of our doctors are going to be in like the 99th percentile of operators of this procedure. And I don't know if you know anyone who's had this procedure done somewhere else where they're not doing this that often. This can be a 2, 3, 4, 5 hour case. And this is and done in the hospital. Sometimes they even use general anesthesia. This is a comfortable environment where you're in and out the same day. So yeah, like Dr. Bernhard, very comfortable doing this procedure. I've done thousands of these procedures. So we have a lot of expertise, not just with the individual operator, but within our whole practice as a whole.
Right. And we have access in real time to that collective knowledge and experience. So you're really getting the collective understanding of 40 different physicians at your fingertips, um, through the fingertips of the one operator that you're working with. Um, is this a bilateral embolization, full PAE? Good question. Um, so a lot of people say, well, how do you treat both sides of the prostate if you're only poking me in the right side of the groin? And that has to do with the fact that of the branching pattern of the blood vessels, we're able to pass from the right side of the groin up and into the left arteries of the pelvis, and then treat the right arteries of the pelvis, typically either first or on the way back. So yes, this is a bilateral procedure in the vast majority of patients. Let's see. A patient asks, Advil seems to help me urinate, especially at night when taken before going to bed. How soon can Advil be taken after the procedure? Well, Advil is one of the medications that we send you home with after the procedure, so you will be taking that right away. Typically, our post-op pain regimen is high dose Advil for the most part, as well as some other medications for inflammation. Why a burning on urination after the procedure? We sort of touched on this a little before. Did you answer that one or? Okay. So burning with urination after the procedure, we're creating an inflammation in the prostate. Um, I kind of explain it to some people. Some people have had prostatitis before. Prostatitis is just refers to inflammation of the prostate. Now, you can have prostatitis most, commonly from an infectious prostatitis. What we're causing is more or less a prostatitis that is sterile, non-infectious, just an inflammation of the prostate by virtue of cutting off the blood flow. So the term ischemia refers to cutting off the blood flow. So you could see this as an ischemic prostatitis or a non-sterile inflammation of the prostate related to reduced blood flow. And the symptoms of that often involve irritation of the bladder and referred pain to the tip of the penis, which are some of the symptoms people experience from their enlarged prostate that make them need to go more frequently, those irritative symptoms we addressed previously. Will I need to go on medication post-operatively that I am not taking now? Only during the week post-operative period. After that, you will not be taking any additional medications from us, and with the goal of getting off any prostate medications down the road. So no long-term medications post-operatively coming from us. My GFR is 23 as I have chronic kidney disease. So can I still get this procedure? Yes, you can. Generally, what happens in this situation is that there's a discussion that happens between myself and your nephrologist, and sort of discuss the risk benefit and what their sense of your kidney stability is. And usually we can come to an agreement. Now, oftentimes doing this procedure, we utilize roughly 20 milliliters of IV contrast. And if you were to get a CT scan of your abdomen with IV contrast, you would be getting anywhere between 100 to 150 milliliters of contrast. So this is already, 5 to 7-fold less contrast than you would get for a CT scan. And so generally the risk of decreasing kidney function from this procedure with 20 milliliters of contrast is pretty low. And we can further dilute the contrast to further minimize the amount that is given, provided that your body habitus allows us to still see things with reasonable reliability and safety. What time does your office open up tomorrow to schedule an appointment? Good question. We open at 8 o'clock. And
I
you can
think that's
always,
the best question to have after a
that's the
webinar
best
like this.
question. Yeah. You can always call and leave a message, and someone will reach back out to you regardless of the time of night. But yeah, our office is open. We perform this procedure Monday to Friday, as well as a number of other procedures, and we also do our consults every day of the week as well.
This was an incredible turnout. Thank you,
Yeah.
Dr. Bernhard, for the presentation. Hopefully, um, you got a lot of good positive feedback. So I think you're going to have a lot of patients reaching out to you.
Oh, that's fantastic. We'll have one final question, and it's how much are my legs inclined during the procedure, and do you give me something to reduce anxiety? And I think I did see another comment about having your head elevated during the procedure. So during the procedure, you are lying flat on the table. The table doesn't move or operate unless it is flat. So we would not be inclining your legs during the procedures. And we certainly give you medicine for anxiety. The sedation medicine we give you typically starts with oral Valium, and then we give you IV sedation in the form of IV Versed and fentanyl as needed on a patient-to-patient basis. Some patients sleep through the whole procedure with just oral Valium, and some patients sleep through the whole procedure without anything. So it's really it's sort of judging you, but you will need to be flat for the procedure. Thanks for the presentation. You're very welcome. All right.
Thank you, everyone.
All right. Take care.